When we see a patient, there's a lot to process. The chief complaint, the age, comorbidities, the context, the general impression, the history from the parents or collateral. All kinds of information bombards our attention and subconscious. Vital signs cut through all of that. In what can be a confusing overdose of info and data, vital signs can help us to find that signal of danger in a wall of information and to prioritize. Now, each person has his own signature baseline vitals, but physiology is physiology. If we listen and look hard enough at the information right in front of us and use what we already know, it can save our patient and us.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. As we know, normal vital signs change with a person's developmental stage. It's interesting, even the ranges that we thought were normal based on decades-old dogma are being challenged now. As much as we hate our electronic medical records, they are great population data catchers, and newer research is challenging what is the true normal distribution. It's too much for us to memorize, so let's take an intuitive approach today. Why is this important? Because bad things happen to people with bad vitals, right? Well, a recent study by Winters et al. Brings out a bit more nuance. They looked at children discharged with vital signs outside of the normal range, and they followed them up. They were able to track 72-hour returns, patient complaints, internal and external referrals for morbidity, mortality review, and deaths. So any of those was defined as an event. In their study, it was common to send a patient home with, for example, fever. 45% of those in the no event group. In the event group, the group, 29% had fever. So fever itself may not be so dangerous, of course, as long as we understand where it's coming from. Heart rate in this study was similar. 56% of children in the no event group were sent home tachycardic, and now we start to see a little bit of a signal. Although tachycardia was common, the event group had more tachycardic patients, 67%. So again, if the temp and the heart rate are linked, and you have a good understanding of why that patient is just a little over what we would expect, and it's explained by the fever, then no problem. Tachycardia out of proportion to what we expect is not. When we look at respiratory rate, the unsung vital sign, we start to get somewhere in this study. Only 9% of the non-event group were tachycardic. Double that in the event group. In other words, those who had an unfavorable event were more likely to be tachypnic. The SpO2 was the same. A low SpO2 in the non-event group was about 15%. In the event group, 29%, so also doubled. Now, correlation is not causation, and this is just a very simplistic frequentist analysis. We have to think about multi-factors when we're trying to figure out why something may have happened. But this study for me just gives us pause. Number one, it's very common to send someone home with just a little fever or just a little heart rate abnormality, a little bit of tachycardia. That's okay as long as you understand why that's happening. This study by Winters et al. Gives us a little signal in all of that complicated noise. Just a little bit of an example of why we should pay attention to the respiratory rate and be careful with that O2 sat. So, I know that you know all about vital signs. I know that you're careful and that you pay attention. Today's talk is more than that. It's about, first, more of a comfort in what intuitively feels right, a facility, an efficiency in when it's okay to say okay and when to say no way. Second, it's about priming us with the can't miss diagnoses that can only be uncovered because we didn't ignore that vital sign that was out of whack. We'll be methodical and go over each vital sign. We'll talk about the extremes as well as a rule of thumb for that comfort zone we're all looking for. Anything outside of that, we just have to stop and think. Respiratory rate in children can be a very wide range. Anywhere from 12 to 44 per minute is normal, depending on the age. Babies comfortably respire in the 40s. A school-age child does not. So hopefully your EMR flags an abnormality to help you, but if you had to think of a number, hold it in your pocket. Let's go with 20 to 30. If someone's outside of that, think who are they, how old are they, and why are they there? 5-year-old Ayana is brought in by her mother because she just needs a refill of her albuterol. Mom thinks little Ayana is coming down with something, and usually that means her asthma is about to flare. Ayana is pretty tired looking. She's breathing fast, and her mucous membranes are a little dry. So let's be careful. Let's put her on the monitor. Her heart rate is 128. Okay, she's 5. That's okay so far. Her SpO2 is 98%. Great. Blood pressure, 102/64. All okay. Her respiratory rate is 46. Why is 5-year-old Ayana breathing at 46? You listen to her lungs. Clear. She doesn't look like she's short of breath, but she is breathing fast. So you think of the differential for tachypnea, and of course, it could be something wonky like the CNS, but maybe more common is going to be a respiratory issue, right? So you're thinking, why are her lungs clear? You think, could this be pneumonia that's hiding? Maybe it's her asthma. She doesn't have enough tidal volume, but no, she's able to take a nice deep breath. And then you think that quiet tachypnea. Could it be a metabolic or acid-base phenomenon? And it turns out Ayana is presenting with her first diagnosis of DKA. Ayana has that quiet tachypnea of metabolic acidosis. She doesn't really look like she's having a hard time breathing. This is not an uncommon first presentation. Now, it's tough because if you were quick to make people happy, she'd be home by now with her prescription for albuterol, getting sicker at home. Konstantinov in 2015 found that primary respiratory symptoms were the most common in preschool children, especially at the time of diagnosis of their diabetes mellitus and when they were in DKA. Moving on to heart rate. There's a wide range of normal, but as we know, your normal heart rate decreases with age. When you think about fetal heart tones, for example, when we check them, the normal is going to be 140 to 160 beats per minute. So really, you should only go down from there over time, unless there's a problem. Conversely, we know that a child who has poor perfusion and a pulse under 60 beats per minute gets CPR. Very different than in adults. Children can tolerate high heart rates, but they cannot tolerate bradycardia. If you have to keep a range in mind that's generally okay for most, think 90 to 120. Again, if they're out of that, just gives you a pause to think, why is this child under 90 or above 120? Sam is a 14-year-old boy who is brought in by his parents because they think he just wants to stay home, and they think he's just being lazy, and they want a doctor's note to show that he is okay to go back to school. Otherwise, he'll just complain to the school nurse again. So that's a lot. Sam had a legit URI last week. He seemed to get better, and now, according to his dad, he's milking it and trying to stay home. Maybe it's drugs, who knows. Sam is tired and looks a bit pale. He has some nausea, some epigastric pain, but his exam is reassuring. so you put him on the monitor. Heart rate is 138. Everything else seems okay, but why does a 14-year-old who is just lying there have a heart rate of 138? Could it be tox? Sure. Infection? Yes. But what about post-infectious complications? I know you know what I'm thinking. Sam has a great history in physical for myocarditis, which usually presents as heart rate out of proportion to the exam or abdominal pain without tenderness, often after a recent infection. Putschel et al. Found that myocarditis in the stable child often presented with a heart rate out of proportion to the exam, and that this presentation was often found in teenagers. The young child with myocarditis may have vomiting, abdominal pain, but a benign abdomen. Teens look tired or freaked out. And now for the vital sign you've been waiting for. Temperature. It's a very popular thing to obsess over because it's the one vital sign whose normal range just doesn't change, but the concern for why this person is having a fever will change with their developmental stage. And unfortunately, so powers the fever phobia. Temperature is temperature. Not too much to add on to this other than please document temperature in children in Celsius. It's the native language of all of our decision tools. And I promise you that you will get something lost in translation when you try to reference something cited in Celsius, but the pediatric patient's temperature is recorded in Fahrenheit. David is a 4-month-old boy born at 37 weeks, no complications. He's had his 2-month vaccines. Mom describes his spitting up pretty much since he was born, and so far you're not that impressed. Until she unwraps him and you see him. He is not looking like a happy spitter-upper. On the monitor we go, and you notice his temp is low. He's been bundled this whole time, so it is not the environment. Rectally, it's 34.2. Uh-oh. Then you look at the rest of his vitals. His heart rate is 96. That's actually relatively low for a 4-month-old. Blood pressure is okay for now at 88/60. So, call it for what it is. This is a young infant with hypothermia who is not feeding well. Remember, a 4-month-old has a pretty limited repertoire, which he should be able to do pretty well by now. That's eat, sleep, eliminate, and cry. And if you're lucky, you'll get a little smile from time to time. David is not okay. Everything is on the table here. Every organ system can be at fault when we talk about hypothermia, especially in infants. And what's that favorite diagnosis that ties the room together so nicely? I agree with you. You were screaming it in your head just now, and I heard that. Sepsis. Perry et al. Found that hypothermia was a reliable indicator of sepsis in young children, especially those less than 60 days of age. Beware of hypothermia. In geriatrics, just like in infants, it's an overwhelming infectious etiology until proven otherwise. Perry et al. Also found that in hypothermic infants, 60% of them had an infectious cause. Morbidity is higher as well in all comers who present with hypothermia and sepsis. Let's tackle the components of blood pressure separately. First, systolic blood pressure. There's less of a range here. For children less than a year of age, there's a hard stop at 70 millimeters of mercury systolic. That is the 5th percentile of normal. The upper normal is the familiar adult 120. So if you had to remember a more conservative range, simply think 100. Brianna is a 3-year-old girl with no past medical history who is brought in by her mother for vomiting over the past day. She's been more tired than usual over the past week, but mom thinks that it's because she's just not sleeping well, family is visiting, and it's a little bit disruptive for her schedule. Brianna looks okay, but she does look tired. Nothing you would be particularly alarmed with. Let's get some vitals. Heart rate is 88. Okay. SpO2, 100%, respiratory rate 28, blood pressure 154/88. Wait, what? Taking care of adults, we can get a little laissez-faire about blood pressure, and sometimes that attitude spills over to children. Don't worry, I felt your cringe there just now. The blood pressure is just too high. Here, Brianna's SPP is way more than we would expect, even for a bad reading. Notice her systolic is up too, 154/88. So there's a lot to think about here, but the quick and dirty is that the younger that you are, the more likely this is to be secondary hypertension. If you have a child under 3 with hypertension, it's renal until proven otherwise. But keep that age wide open. We never know what our patient's previous access to care is. Just a quick rule of thumb here. The AAP guidelines for hypertension in children are a hard read. Here's a formula that I made up to crystallize their very conservative ranges of blood pressure. If the patient's SPP fits this, he or she is good. If it doesn't, it just means you have to think a little bit more about it. So 100 plus age is the normal upper limit for systolic blood pressure. At 1, you are 100. At 3, you're 103. At age 5, you're 105 until you reach the adult 120 millimeters of mercury. Okay, let's move on to one of the vital signs that gets ignored a lot, the diastolic blood pressure. Normal is a more narrow range. If you had to remember something that's helpful, think 60 to 70. Keith is a 10-year-old boy who was skating down the hill when he cut into cross traffic and he couldn't stop and was hit by an SUV and flung 15 feet. When he arrives, he's awake but distracted by his pain. He has an obvious femur deformity. He's awake and crying. Here are his vital signs. Heart rate, 90. SpO2, 99. Respiratory rate, 22. Okay, great. Can we find a blood pressure cuff that fits him? Okay, fumbling. 110/90. Okay, fine. Let's control his pain. Let's do some screening labs and films, and we'll be right back. Wait, what? 110/90? That diastolic, though. What's the issue here? It's not CNS. Not any one solid organ system, but why would his diastolic be abnormally high? What's going on here? Remember our old friend, pulse pressure? It's basically stroke volume times the compliance in the system. In adults, the pulse pressure predicts cardiovascular disease. It predicts valve dysfunction, all kinds of other things. In children, the physiology of pulse pressure is totally different. In fact, pulse pressure is an indirect way to measure and track what can be elusive, the systemic vascular resistance. This is the child's first and major defense against poor perfusion. Squeeze down on the SVR to keep that pressure up. So a narrow pulse pressure in children is shock. Most commonly, it's hypovolemic shock from fluid loss, and in this case, hemorrhagic from the trauma. And narrow pulse pressure is what happens when the systemic vascular resistance goes up. And you may even see this on exam with cooler extremities. A wide pulse pressure is not as common in children, mostly because of their ability to increase their SVR in the setting of shock. It's just remarkable. Usually children present in shock with cold shock, so that high SVR, narrow pulse pressure. But in severe shock, if they're decompensated or if they have neurologic injury, they can present as a distributive shock. So if you see a child who has a wide pulse pressure, that is a near extremis state. Again, SVR, the main way that we can cope with shock. If that gives out, you're in trouble. Pay attention to a narrow pulse pressure, but be ready for a crash if there's a wide pulse pressure. Moving on to pulse oximetry. Don't you feel more powerful already? Pulse ox is like temp. Normal is normal, and interpretation has to be done in context. Cindy is a 7-month-old baby girl born at 35 weeks, so a little premature. She was a feeder and a grower in the level 2 nursery. She comes in because she is full of nasal discharge, really a waterfall, and breathing fast. Cindy has a little head bobbing with intercostal retractions and that faint tissue paper-like wheeze through all lung fields. Little Cindy has the bronchiolitis. So she gets some vital signs. Her pulse ox is not awesome. It's 92%, and everything else is reasonable. Well, what can be the cause? Well, if it wheezes like RSV and drips like RSV, it's RSV. One thing I wanted to bring to your attention, though, is the BIDS study by Cunningham et al. In The Lancet in 2015. It's something we should all be proficient in because it may be used against you when you're trying to admit a baby for bronchiolitis. It's a very nice study, very well done. We just have to know its limitations. The issue is that sometimes it's true we worry more about a number than the patient. That's the argument that the study was based on, but there's more to discuss here. Cunningham et al. Randomized babies to a normal pulse oximeter and a modified pulse oximeter. That modified pulse oximeter showed 94% on the readout, even if the actual pulse ox dropped to 93, 92, 91, all the way down to 90%. On the modified monitor, if it dropped to less than 90%, then and for a safety mechanism, it showed the actual pulse ox. But the whole point is, what do we do with that information when we think that someone who actually is in between 90 to 94, and we think they're actually better by numbers? So they saw all these children through, they followed them up, and they reported that there were no difference in outcomes whether we used 94% as our cutoff for hypoxia or 90%. Now, this was in the UK. It's a different system than I'm used to practicing in. There's different access issues. I mention this article because, yes, on the one hand, a number is a number, and we can get really worked up about certain data points. We're not looking at the patient, we're looking at that number. But on the other hand, we have to take the presentation in as a whole. We shouldn't focus on that number. We should focus on the patient, but at some point, we got to call it. Pulse oximetry is only part of the picture. Bronchiolitis, as we know, is the pneumonia we just can't treat. It's time that we'll treat the pneumonia that is RSV bronchiolitis. The respiratory syncytial virus literally turns your alveoli into a syncytium, a coalescing glob of dead cells and virus, turning your beautiful fluffy baby lungs into wet cotton candy. It takes time to get better, and they usually peak in symptoms on day 3. They improve over the next week or two. To go home safely, you need to be full term. There has to be no cardiac, neuro, metabolic, genetic, or any other comorbidities, and the child has to be well appearing, not hypoxic, and euvolemic. So it's that non-hypoxia that's the catch. I like my babies 94% and higher. But it all depends on your system, whether you can get home O2, whether this is day 1 or day 5. All of those things matter, and you can use your best clinical judgment. Do what you can, and I'll endorse you. Moving on to our youngest star in the vital sign sky, entitled CO2. When are we using this? Usually in sedations or in critically ill children. Normal is the same, children or adults, 35 to 45. Araceli is an 8-year-old girl. She's healthy, at a family party, jumping up and down on the trampoline. She comes in with her both bone forearm fracture. She's getting sedated. All was going well. She got a whole lot of propofol, and there's a lot of equipment in the room, and an alarm goes off. Now, what's the first thing that we need to do? First, we need to look at the patient. First, look at Araceli. She's covered in blankets, so you have to pull them all off. You look at her chest rise, and it's not great. The alarm keeps screeching. Heart rate is 72. Oxygen saturation is 99%. Okay, respiratory rate is 12. That's weird. And her end-tidal CO2 is 22. That's low. But more importantly, you look at the waveform, it seems to be getting smaller and smaller. What's going on here? Sometimes the quantitative end-tidal CO2 can be a little bit wonky. Maybe the sensor is not where it should be. We've all been there where we see the totally normal, spontaneously breathing patient. His or her end-tidal CO2 nasal prong is somewhere in the forehead zone. But the qualitative end-tidal CO2, the waveform, this is where we see the normal exhalation. And in her case, in Araceli's case, we see a diminished reading. Little by little, every waveform is getting smaller and smaller, and she doesn't look like she's moving a lot of air. This is hypopneic hypoventilation. So the end-tidal CO2 is decreasing, but the arterial CO2 will rise if you don't do some airway maneuvers. You look, the O2 is still good. The end-tidal CO2 literally gives you that breath-to-breath take on ventilation. And if she's getting supplemental O2, she may not desaturate right in front of you, but it's an early warning sign. Remember, the end-tidal CO2, those waveforms are a breath-to-breath look at what's happening. Now, it is true that since this is a marker of metabolism, literally we are measuring the expired CO2. Anything can be at play from the cellular level to the circulatory system to the pulmonary circuit. The things that increase your end-tidal CO2 are muscular activity and fever on the cellular level, or resuscitation and releasing a tourniquet on the circulatory level. Other things that increase your end-tidal CO2 on the pulmonary level include decreased minute volume or bronchorelaxation. Things that decrease your end-tidal CO2 include paralysis, hypothermia, if you're thinking of the cellular level, or low cardiac output and pulmonary embolism on the cardiovascular level. Other things that decrease your end-tidal CO2 on the pulmonary level include bronchospasm, increased minute volume, or just plain hypoventilation, something we commonly see with propofol. There is bradypneic hypoventilation, where you don't ventilate enough because you're breathing too slowly. And this is typical of an opioid overdose. So your waveforms are big and long and fat, but you're actually hypoventilating because you're doing it way too slowly. The end-tidal CO2 will read normal to high with a very slow rate. If this is something we gave the patient, you can simply monitor them. If it's something where you think their trajectory is going in the wrong direction, then realize that they are going into a bradypneic response. The other type of hypoventilation is hypopneic hypoventilation. This pattern is commonly seen in sedatives, so in benzodiazepines, in some hypnotics, and definitely in propofol. Although the end-tidal CO2 reading may not change, the patient's pulmonary arterial CO2 will rise, putting that patient at risk for acidemia. So we need to reassess that patient's level of sedation. If the oxygenation is compromised, we need to open that airway and reposition, give supplemental O2 if needed, and hold further sedatives. This is a perfect example of the normal propofol effect. This is what happens when we give propofol. It's okay as long as we pay attention and don't push more. In summary, we see such a wide range in vital signs in children that we may miss something that is just out of what we would expect. Breathing just a little too fast and too quiet. Think metabolic, and preschoolers may have their first presentation of DKA this way. Listen to the lungs, but think about checking that sugar. Heart rate out of proportion to the fever, or what seems to be low-risk chest pain with tachycardia? Think again. Think myocarditis, especially in teens. Hypothermia in infants can be a sign of badness. It's usually sepsis. The mortality in sepsis with hypothermia is higher than sepsis with a fever. Their cellular machinery is shutting down, so it's time for us to power up. Systolic hypertension. Normal is 100 millimeters of mercury plus the age. This is extremely conservative, but if you're around this number, you're okay. If you're wildly higher, think of secondary hypertension, especially in infants and toddlers, and think renal. Diastolic hypertension doesn't sound so bad until you realize that this is a marker of a narrowed pulse pressure. And that is the systemic vascular resistance screaming, "Help! I can't hold on much longer." Low SpO2 has to be interpreted with the disease process. If this is a reversible thing like asthma, we can watch and see as that VQ mismatch settles down. Pneumonia? Well, that's not getting better anytime soon. And bronchiolitis, of course, is the pneumonia you can't treat. Only time treats bronchiolitis. I like my babies above 94. My hard cutoff is 92%, but that's going to vary with your institution and resources, and more importantly, with the patient himself. End-tidal CO2 is a great adjunct to sedation and even resuscitation. Look at the quantitative and the qualitative readings together. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.